Capsular bag distension syndrome has seen an increase in incidence due to the reduced diameter of capsular rhexis. With various anterior capsulotomy innovations and increased awareness regarding the need for uniform capsular overlap, anterior capsulotomy with reduced diameter has become the new norm. In pseudoexfoliation syndrome, a three-piece IOL is implanted in the sulcus with optic capture by the anterior capsular rim. These two situations, particularly with retained OVD, are associated with increased risk of capsular bag distension. Early capsular distension syndrome is associated with retained OVD in the bag posterior to the anteriorly displaced intraocular lens. This results in a shallow anterior chamber, myopic shift, and a hike in intraocular pressure. In contrast, late capsular distension syndrome presents with defective vision, and the diagnosis can be made at the slit lamp, where you will see retrolenticular collection of turbid fluid in the bag with a clear capsule. Near complete aspiration of OVD from the bag is a crucial step in minimizing this problem. IOL implantation under continuous irrigation prevents retention of OVD in the bag. In patients at high risk for capsular bag distension, like those with a smaller rhexis or a sulcus fixated IOL with optic capture, or those with greater axial length, a peripheral anterior capsulotomy is created using a 26 gauge needle after IOL implantation. This is done under continuous irrigation. This creates a communication between the bag and the aqueous, reducing the chances of capsular distension syndrome. The current treatment modality for capsular distension syndrome is yard laser capsulotomy of the anterior and posterior capsule. Anterior capsulotomy releases turbid fluid into the anterior chamber, leading to transient inflammation and increased intraocular pressure. Posterior capsulotomy is technically easier, but with the attendant risk of retinal detachment and propionibacterium acnes endophthalmitis. An increased awareness of this entity will help the surgeon to pick up early cases of capsular distension syndrome and manage appropriately. A simple step of peripheral anterior capsulotomy will completely eliminate capsular distension syndrome.